my awesome people, we are back with very important mini micro videos of high yielding stuffs, and we have already discussed renal cell carcinoma. We'll move to something very important and useful topic for you all, that is oncocytoma. Now you should also know how they look like and what all is their important features. Now oncocytoma is a solid renal mass, that is tumor, which constitute around 3 to 7% of all solid renal masses. So these can be very confusing with the chromophobe type of renal cell carcinoma. So as you already know about chromophobe renal cell carcinoma, these are difficult to be differentiated from eosinophilic malignancies, both clinically and radiological means. So how they look like pathologically: these tumors are light brown or tan, homogeneous and well circumscribed and not truly encapsulated. So I will show you the exact thing which I have been talking to you, and there will be a central scar without prominent necrosis or hypervascularity. Ultrastructurally, if you see, there will be numerous large mitochondria which will be contributing to its distinctive staining pattern. Now, how they are diagnosed on CT scan? On CT scan, these oncocytoma have a very definite and certain feature that is called central stellate scar. So this is very important feature which I will show you on CT scan, that how you will recognize a oncocytoma by its central stellate scar feature on CT scan. On angiography, you will see a spoke wheel pattern of feeding arteries. So it will be like something like this. So oncocytoma is a tumor which NB people are very fond of asking, so you should know every point about it. So these have a central stellate scar and distinctive intensities on both T1 and T2 images for MRI. Treatment is a nephron sparing nephrectomy is preferred. So you can just excise is the oncocytoma, as mostly these are benign. So in what all other condition you will see the central stellate scar? So in case of serous cyst adenoma pancreas, in case of fibrolamellar hepatic cell carcinoma, and in case of renal oncocytoma. Now I would make you see this this oncocytoma, how it looks like, because it is very important for you all to know it, how it is going to be asked in your examination. So you see this is a Wikipedia image, so they can ask you this image also, because Wikipedia is something which is the most common source from where they are asking the images. So if you see here grossly also, you will observe the spoke wheel patterns, central scar and spoke wheel pattern. So this is a typical oncocytoma tumor which you can see grossly. So here again you can see a fibrotic core and the surrounding tumor. So this is a typical oncocytoma picture, and here on CT scan you can see the different compartments and spokes being visualized here. So this is a oncocytoma, you can easily recognize after seeing these images. Now moving to another very important topic, that is they ask is, if I ask you through image, can you tell me the condition? This is also oncocytoma, again oncocytoma. Now tell me this condition. So yes, this is Mondor's cord seen in Mondor's disease. So if I ask you what is Mondor's disease, which is very frequently asked in your examination, it is the superficial thrombophlebitis of the superficial veins of the anterior chest wall and breast. So it is a variant of thrombophlebitis which involves only the superficial veins of anterior chest wall and breast. It is also known as string phlebitis, as you have seen a string, that is Mondor's string, a thrombosed vein presenting as tender cord-like structure. So what will be the symptom? It will be a pain in the lateral aspect of breast or on the anterior chest wall. So you will observe a tender firm cord in that region. So frequently involved veins are lateral thoracic vein, thoracoepigastric vein, and superficial epigastric vein. So these are the important veins which are involved, which your examiner can ask. Okay, so lateral thoracic vein, thoracoepigastric vein, and superficial epigastric vein. So it is usually a benign self-limiting disorder and is not an indicative of cancer. But yes, it is new thing and NB people are fond of asking. That is why you are reading it and I am making you learn this. So when the diagnosis is uncertain or when the mass is present near the tender cord, biopsy is indicated. Treatment is usually by NSAIDs, application of warm compress, and along with symptomatic vein with restriction of movement, and usually resolves by symptomatic method by 4 to 6 weeks. And if it persists, then excision of the involved vein is recommended. Now something about hepatocellular carcinoma. So sorafenib is a drug which is revolutionary in case of hepatocellular carcinoma, so you should know how it works. So if you see, it inhibits the serine and threonine kinase RAF1, vascular endothelial growth factor 1, 2, 3. So it has multiple action and it inhibits multiple things like RTK, RE8, FLT, and c-KIT. So these are the things you need to just read and revise yourself. So it is the approved standard therapy for unresectable hepatocellular carcinoma. Okay, so some other questions related with hepatocellular carcinoma is paraneoplastic syndrome is very important topic again in case of pathology. So what all paraneoplastic syndrome are associated with hepatocellular carcinoma? So hypercholesterolemia is the most common among them, then hypoglycemia, erythrocytosis, and hypercalcemia. So you need to remember this hypercholesterolemia. Now if I ask you some random one-liners, so what is the most common primary liver malignancy? So again it is hepatocellular carcinoma, and it represents most common solid organ cancer overall also. So hepatocellular carcinoma is fatal and most common cause of death in patients with cirrhosis. It is the incidence is 100 folds high in individuals with hepatitis B infection. These are more common in male and has 60 to 90% more risk, means more chances in case of cirrhotic liver. Now post necrotic cirrhosis has highest risk of developing hepatocellular carcinoma. So post necrotic cirrhosis, okay, so you need to remember necrotic and cirrhosis. Alcoholic and primary biliary cirrhosis are comparatively at lower risk. This hepatocellular carcinoma derives its arterial supply from hepatic artery, and how you are going to identify why it is important this vascular supply is because you identify it on imaging by hyperdensity on arterial phase of contrast, means they have more arterial perfusion. So hepatocellular carcinoma is a very vascular cancer and it shows a hyperdense feature on arterial phase of contrast. So this is an important MCQ they ask regarding hepatocellular carcinoma from imaging. So arterial perfusion allows us for treatment of the lesion by embolizing the feeding artery. So it also serves in diagnosis as well as in therapeutic treatment of hepatocellular carcinoma. So characteristic is propensity to invade the portal vein. So how you are going to identify, another criteria is the hepatocellular carcinoma invades the portal vein. So this is something which most of the people don't know, so you should focus on. So risk of portal vein invasion is another importance, is it appears to correlate with the tumor size and differentiation. So these were some important points regarding hepatocellular carcinoma which you should know. Moving to the third important topic, which is different types of hernia. So this is something which every surgeon will know, and so you should also know regarding your surgery. So Gibbon's hernia is a hernia along with hydrocele. So what you can do is, there are so many hernia types, you can just form an image memory of them. So you can imagine a gibbon with a hydrocele and a hernia. So whatever image you are having in your mind, just imagine it. Although funny, but they do help in your real examination when you are in front of computer screen. When you have to rule out among the option, you will get an image of this gibbon with a hydrocele and hernia. So you can easily point it out that the gibbon, you have imagined a gibbon with the hydrocele along with the hernia. So whatever is the clinical or the important stuff, so you should know about the anatomy. But this is the thing, because our main purpose is to get a rank in NeetPg, so we cannot afford to miss any question. So gibbous hernia, a hernia with a hydrocele in a gibbon. Okay, so this is something which means in this form you can form any image and just remember them. So Berger's hernia is hernia into pouch of Douglas. Beckler's hernia is femoral hernia through opening of saphenous vein. Amyland's hernia is inguinal hernia containing appendix. Okay, so Amyland is important, gibbon is important, pouch of Douglas, Berger's is also important. Ogilvy hernia, so Ogilvy is also important. So these are some of the hernia which have been already asked. Hernia through defect in conjoined tendon just lateral to where it inserts with the rectus sheath. So rectus sheath and Ogilvy hernia. Okay, Stammer's hernia is again very important one, which occurs through the window in transverse mesocolon after retrocolic. So this is another very important. You can also see the image of this Stammer's hernia. So this is a hernia which occurs through a window in transverse mesocolon after a retrocolic gastrojejunostomy. So transverse mesocolon and Stammer's hernia. Peterson hernia is also important. Hernia through Ruick's limb through Rowenix Y gastric bypass. So these were some important hernias. Laparoscopy, some points very easy, you all must be knowing, but I'll just read it. Needle is known as Veery's needle. CO2 is used. Flow is 1 liter per minute. Intra-abdominal pressure is 12 to 15, because everything is now laparoscopic. So they will ask you even a basic question, but they will ask you something from laparoscopy. So you should know the port size, how many ports are used, where they are placed, and in what operations, how they are used, and the laparoscopic instruments, which I will discuss later. So trocar is inserted at or just below the umbilicus, penetrating the skin, superficial, deep fascia, fascia transversalis, and parietal peritoneum. So they can ask you the sequence: skin, superficial, and deep fascia, fascia transversalis, and parietal peritoneum. So post laparoscopy, people experience shoulder pain. So that can be due to CO2 retention causing irritation of the diaphragm, and referred pain is through the phrenic nerve to the shoulder. So these were the some important points which I wanted to convey. So stay happy, stay focused, keep your faith high, be consistent with your efforts, and everything will seem to be working out. So this is Dr. Shivam. Stay happy, stay confident, stay cool, and do whatever you want to do. Thank you.